Now, let's talk a little bit about diagnosing. I truly think that diagnosing and the way dentists diagnose fillings is one of the reasons everyone hates fillings. First of all, just because you can do something doesn't mean you should do something. It doesn't matter how bad a tooth gets. Technically, you can still do a filling on it. But again, just because you can do something doesn't mean you should. You need to establish criteria for how you want to operate as a dentist. If you don't, you'll be manipulated by every person you treat. Not only will they pressure you to do things that you shouldn't, but if it doesn't work as the patient has it in their mind, you will be blamed. The phrase "no good deed goes unpunished" is absolutely applicable to the field of dentistry. Whenever you try to become a hero or help somebody by compromising your diagnostic standards, it will come back to bite you, and you will only have yourself to blame. As a dentist, I want to do things that work. I want to do dentistry that lasts. My diagnostic criteria are simple. I want to do treatments that will most likely last at least 10 years. Now, I'm not guaranteeing that, and I know nothing is perfect, but I want to provide options that I feel have a great chance of lasting 10 plus years. Do I think realistically that a huge MODBL filling that undermines cusps and is wider than is reasonable will last 10 plus years? Probably not. So I don't really want to do that. Giving patients cheaper options that aren't going to last doesn't help them. It's a cop-out for you being too weak or too afraid to tell them what they actually need. I'm not saying that you should be an elitist and not help people unless they do exactly what you want. I am just trying to help you get in a position where you won't get burned. You might think another dentist is overdiagnosing because they would do a crown in a case where you would do a filling. But more than likely, they're not overdiagnosing. You just don't know enough yet. Of course, there are cases where someone goes outside the standard of care and overdiagnoses, but I think those cases are far less common than we actually think. I found that dentists are far more likely to underdiagnose than overdiagnose. And I would say in my experience, it's multiple orders of magnitude more common. If you diagnose less than somebody else, you're not better than them. If anything, you should be asking yourself, what are they saying that I am not? For fillings to be successful, you have to diagnose appropriately. Many dentists think that fillings are too complicated, annoying, and too much work. The reality is that most of the time, they are too much work because you are diagnosing them wrong. You can absolutely diagnose fillings that are horrible, unproductive, and make you hate dentistry. I'm just saying don't do that. You control what you diagnose, and you can't do it unless you diagnose it. If you are doing incredibly complicated, unproductive fillings, it is because you diagnose them. As you increase your studies of dental fillings, you should start to be aware of which fillings you like, are easy, and which ones are not. As you continually pay attention, start to refine your diagnosing to get more of the fillings in the category that you like to do. If you don't like doing fillings on the distal of wisdom teeth that wrap around both sides, then stop diagnosing them. Maybe instead diagnose those fillings. It's a referral or wisdom tooth removal. There are often different ways to approach things. As you start paying attention to the fillings that you don't like to do, start mapping out different ways to approach those situations. You have multiple options. You could either not do those and refer out as an extraction or something like that if they're really bad, or you can decide to do a crown or do a different procedure instead of the filling. Depending on the situation, you can say that the filling requires a different procedure or material to properly treat. One example would be to use a laser to do a gingivectomy and then do a different type of filling. You can charge differently for different procedures or different circumstances. You can also research and find different materials that make the situation more possible. Again, this would be a procedure outside of the typical filling that a PPO pays for. You can start to see that, yes, this might take a little bit of work, but considering the vast majority of dentists are bored and complaining of experiencing burnout in the profession, this seems like a fantastic way to channel your energies and actually get really good at this stuff. This isn't going to happen overnight, but every situation that you look at and solve to make it fun, rewarding, and profitable is progress. Little by little, before you know it, fillings will start being more fun. Heaven forbid you might actually look forward one day to quadrant fillings, but let's not get too far ahead of ourselves here. You need to establish specific criteria. You need to diagnose fillings in a way that if you look at your schedule and you see 19 occlusal and 20 DOL, you know exactly what you're walking into. You should never be surprised. If you are surprised by something being much bigger than you expected, you likely strayed from your diagnostic standards. Now, I know everyone is very sensitive about some of these diagnostic details, so I'll share my opinion. If you want to tweak or adjust it based on your own thoughts, that's fine. I'll share the way I do things because I found it very effective. Diagnosing fillings incorrectly is one of the worst things that you can do. If you go into an appointment and have to add surfaces and increase the cost, the patient will never be happy. However, if you diagnose an OBL and it turns out it's smaller than you thought, it's not a big deal to decrease the surfaces after you've completed it. If you try and do a deep filling when a root canal should have been diagnosed, then when it goes bad, the patient will hate you and come after you because the tooth was fine until you did a filling. Now it is a toothache. No good deed goes unpunished. Patients never complain when something is easier, better, or less expensive than they expected. Also, if something turns out smaller and you tell the patient it was easier than expected, they'll assume you're a really good dentist because you made it easier than it should have been. It's a definite win-win. This perception thing goes both ways. When I diagnose an occlusal, I'm looking for something pretty small, likely something I can do almost without any anesthetic. So when I see an occlusal on my schedule, I know there's a good chance I can probably do it without anesthetic. Now, if I have a tooth with decay in the pits and fissures that's clearly bigger than something I would do with a fissurotomy burr or without anesthetic, then I'll at least add a buccal or lingual to that. If I see an occlusal buccal or an occlusal lingual, I'll likely know that I'm going to be adding or using anesthetics during that appointment. The caries are large enough that it's not going to be a quick little fill. If I look at my schedule and I see 18 and 19 OBL, then I know that these are likely on the bigger side of fillings and won't be nearly as fast. Sometimes one of those fillings might end up being one surface smaller potentially, but most of the time that diagnosis will be fairly accurate to what I'll bill out. This is helpful for me because there's a big difference in how I approach appointments and scheduling when comparing single occlusals to an OB or an OBL. How many of you have gotten one or two occlusal fillings, put them in your schedule, and assumed it wasn't a big deal? But before you knew it, the appointment takes forever, trashes your whole schedule, and if you would have diagnosed appropriately, that wouldn't have happened to you. Sometimes when I fill in for a doctor, I'll look at their schedule and see a couple of occlusal fillings on wisdom teeth, and it's incredibly rare for a wisdom tooth to need a single surface occlusal filling. They're always bigger. So I'll never diagnose a single surface occlusal filling on a wisdom tooth or other complicated teeth. They're always bigger than they look. This is also very helpful for same-day dentistry. If I have a handful of occlusal fillings, I know I can likely work those in any time throughout the day because I'm minimizing the need for anesthetic. On the other hand, if it's multiple 3 surface fillings, I might be less inclined to work that appointment in at different times of the day because I know more is going to be involved. Okay, so now that we've discussed occlusal fillings, let's talk about interproximal fillings. I use a similar philosophy for diagnosing interproximal fillings. For me, slot prep interproximal fillings are incredibly fast and predictable. When I see a deal on my schedule, I know I basically have to drop a slot with minimal widening, and 95% of the time, that will pretty much take care of all the decay, often without even having to go grab a round burr. I diagnose 2 surface interproximal fillings in a way that I can do fast slot preps without chasing decay. They're very fast and very predictable. On the x-ray, this looks like decay hitting the DEJ but not extending past it in a way that I can see caries into the dentin. To me, that's a 2-surface interproximal. The moment you see caries on the x-ray or notice more extensive decay clinically, it becomes at least a 3-surface filling for me. And if I sense that it's slightly bigger than what a slot prep would be, I'll likely diagnose it as a DOL or a DOB. So when I see a 3-surface filling on my schedule, I know pretty much exactly what it's going to look like without even looking at the x-ray. The moment you can see actually decay in the dentin, it is highly likely it will extend the base of your box to a point where it makes sense to include that additional surface. Now, when I see something more significant, clearly into the dentin with obvious caries clinically, I'll likely call it a DOB. Now, when I see something more significant, clearly into the dentin with obvious caries clinically, I'll likely call it a DOBL. Again, don't get overly caught up in this because you can always fine-tune the surfaces at the end. The reality is this is pretty accurate, and I rarely have to change many surfaces when I'm done. If there is an interproximal decay on both sides of the teeth or the tooth, and it fulfills my 2-surface criteria, then it's simply an MOD. If one side has slightly more decay, I'll add a surface like a lingual or buccal. This is where you need to be specific about what you'll diagnose as a crown. If both sides of the tooth have significant decay, larger than what I would call a 3-surface filling, you're likely into crown territory. It does not take much for an MOD to be larger than 1/3 the occlusal width or to undermine a functional cusp. I won't decide for you what your red line is, but you need to have one. a point where you'll no longer do a massive MODBL filling and start considering a crown. It's not worth arguing over what's too much or what's not enough. I'd rather recommend looking at the traditional definitions of crown diagnosis. Most dentists aren't sticking to these criteria, and if they did, they'd probably do a lot more crowns. If we actually stuck to these definitions, we'd be doing a lot more good dentistry, and we'd feel good about it because we're rooted in science. For example, some criteria suggest that if the intercuspal width is anywhere from 1/3 to half of the tooth, it needs a crown. If there's any involvement of functional cusps, it typically needs a crown. For maxillary teeth, those are the palatal cusps, and for mandibular teeth, those are the buccal cusps. But realistically, if a cusp is involved, you likely need a crown. Another criteria involves remaining wall thickness. If they're less than 2 millimeters thick, the tooth probably needs a crown. Next time you're in the mouth, measure that for fun. It's actually thinner than you'd think. Other factors include occlusal loads. If the tooth is a first molar or shows signs of bruxism, or if the patient is missing adjacent teeth, increasing the load on that tooth, that might push it into the crown territory. If the decay is close to the nerve, the depth of the restoration can also reduce structural integrity of the tooth enough to warrant a crown. So just choose to do dentistry that lasts. Much of the unpredictability that you face throughout your day is based upon your inconsistent and undisciplined diagnosing. Let's briefly review this. So step 1, you need to create consistent diagnostic standards for yourself. After you are consistently diagnosing based on your standards, then you can start improving the fun and profitability of each of these situations. Step 2 is to start scheduling your newly consistent diagnosed fillings in a way that is fun, profitable, and rewarding. Step 3 is to start making a list and noticing any situation that is not fun, predictable, and profitable. You will then take each of these situations and develop a new way to approach that situation, as we discussed earlier. You will then be in a place where dental fillings are now consistent, predictable, and starting to be pretty fun. Then you can focus more of your energy on the actual treatment and becoming more efficient and successful in your clinical procedures. This is how you can diagnose in a way that you can stop being burnt out in dentistry and start having some fun and making this a truly rewarding and fulfilling career. So let's work together to make dentistry more fun, rewarding, and fulfilling. Don't forget to subscribe and stay tuned for more.